see all the valvular heart disease are some acute causes of valvular heart disease and some chronic causes of valvular heart disease. And in mitral valve disease, if you will see mitral stenosis and mitral regurgitation and mitral valve prolapse. So these three diseases are most commonly, if we combine this, we will call it mitral valve disease. So how it is acute in mitral stenosis is very rare causes of acute diseases. It is usually a chronic, like rheumatic is again is the most common. If you will tell me first, second, third is common, again it's rheumatic. Mitral regurgitation, it can be acute, it can be chronic, and in mitral valve prolapse, initially it takes some time to be symptomatic, and mitral regurgitation comes in very later. So what are the valvular diseases like valvular, subvalvular, and supravalvular diseases? So I will tell you what is commonest cause is mitral stenosis. If you will see LA pressure and LV pressure, everyone knows the LA pressure is lesser than the LV pressure. So once the why I am saying the LA pressure, because some 50% of MD are there, and everyone should know the basics of the mitral stenosis. Why patients affected? We know that in mitral stenosis, before patient symptomatic, at least the disease is prevalent in your body at least 1 decade to 2 decades. So you just imagine patients had mitral stenosis 2 decades before, and now you are symptomatics, or 1 decade before. So this basically the pressure curve is between the LV and the LA pressure. Once there is mitral stenosis, how the LA pressure increase and the patient's back pressure transmitted with pulmonary valves, pulmonary veins, then pulmonary venous congestion, then patient symptomatic. This pressure curve will give the fine data, but still we should know the some rarest causes like congenital, some radiation, myxoma, mucopolysaccharidosis, and severe mitral lunar calcifications in elderly patients. So how they presented to us in clinical. Sometimes, why I am telling you mitral stenosis, sometimes some patients they roam around physicians, by chest physicians, cardiologists. Sometimes they are misdiagnosed like dilated cardiomyopathy, like bronchial asthma. But then if you ask me the classical symptoms, how they present, sometimes they simply presented with hemoptysis, they presented with acute left ventricular failure, or sometimes they presented with just dyspnea on exertion class 2 to class 4. So according to the history, past history of rheumatic heart disease and acute presentation of the dyspnea and some pedal edema and fatigability, some palpitation, we ask the patients to the previous history of whether joint pain was there or not, patients having fever or there or not in childhood, and these are more common in low socioeconomic status group because of the the history of rheumatic heart disease, the streptococcal infection, the joint pain, the fever, fleeting arthritis. Again, Michael, sometimes some patients they didn't give any history of joint pain, they didn't give any history of the fever, they don't give any other history, only their past presentation with what I told, these are the histories. So from the clinically, we have to see from the pulse, from the JVP, from the vessel crabs, from the heart sounds. We have to, these are the signs like you have to see pulses, how the pulse, it may be irregular, may be absent, reduce, and that is low systolic, and sometimes peripheral edema, and sometimes rapid heart rate. And if you will see the classical heart sound is loud first heart sound and diastolic 3. So and P2 is loud, there is opening snap. Sometimes we may not get anything in severe calcific mitral stenosis. So Why I am telling you the mitral, before going details into the treatment modalities, first you have to diagnose the disease, then only you can go. So once you will suspect that I am dealing with the patients, you have to suspect, because patients having history, then clinical examination, then you have to go on electrocardiographic, chest X-ray. There will be find your left heart border is just straightening of the left heart border. There is pulmonary venous congestion. So we will go the double atrial shadows and echocardiography classically diagnosed. So if you ask one diagnostic parameter, then I think this is the gold standard to diagnose the mitral stenosis. You have to see the mitral valve thickness, the calcification, the thick and doming, and there are the variety of scores. We have to then we have to know which whether how the valve is, whether valve is mobile or not, whether it is mild, moderate, or severe mitral stenosis is there, whether there is LA clot is there, or there is LA appendage clot is there or not, and associated with mitral stenosis, whether any other abnormalities are there, like mitral regurgitation or any other valvular regurgitation, other valvular involvement is there or not, how the right-sided heart is involved, whether the how much pulmonary artery pressure is increased. Even some mild to moderate cases, if you get the severe mild pressure of the pulmonary pressure, then the indication of treatment will be different. So the classical or gold standard diagnosis is the echocardiography, and from there you can know everything. You can know the pressure, you can know the area, you can know the dilatation of the heart, you can know the calcification score, and whether patients was meant for the surgery, medical management, or any balloon, everything we can go from the echocardiography. Then you can have also one parameter like cath study, but nowadays echo is excellent, so it is the gold standard of diagnosis. Second, electrocardiography. Sometimes we get rapid ventricular rate, sometimes atrial fibrillation, atrial flutter fibrillation. There is P pulmonally, the left atrial enlargement will be there, sometimes right atrial enlargement was there. And in complication, there may be atrial fibrillation, peripheral embolism, pulmonary hypertension, and isolated infective endocarditis is very rare. But in combination with mitral stenosis, with mitral regurgitation, we can get infective endocarditis. Otherwise, it is very rare in isolated mitral stenosis. So how we will proceed for the treatment? If patients have sinus rhythm, then with patients have sinus rhythm with severe mitral stenosis, so you can start with the beta blocker, diuretics, and if with atrial fibrillation, then from this you have to start from the digoxin and some verapamil or amiodarone to control the ventricular rate, beta blockers, and anticoagulation. Anticoagulation is a must if a patient having atrial fibrillation or patients having spontaneous echo contrast in the LA, left atrial appendage, or there is already thrombus in the left atrial appendage. So how you can first you have to control the ventricular rate, and you have to anticoagulation to prevent the thrombosis to migrate to the that means to prevent stroke, peripheral embolism, and the treatment modalities we have to go according to the valvular structure, the area, the pulmonary arterial pressure, and the thrombus. If you will say the invasive, once patients having severe mitral stenosis, you have to go for invasive treatment. If there is no thrombus, then we should, and patient have low calcium, then we can send the patients for valvuloplasty, like mitral valvuloplasty. Previously, surgical treatment like closed mitral valvulotomy was prevalent. Now I think it is surgeons are not doing it. So in percutaneous PTMC, whatever percutaneous transluminal mitral commissurotomy or balloon mitral valvotomy is the treatment of choice when there is low calcium score, more severe mitral stenosis with pulmonary hypertension. And if there is atrial fibrillation, then it is little bit difficult because lateral enlargement will be very high. The other is mitral valve replacement. So one is mitral valve replacement, another is closed mitral valvotomy. In closed mitral valvotomy, there is no need to open this chest. You can go from a lateral thoracotomy and you can just open the mitral valve with your finger. And in other is valve replacement. Either in mitral valve replacement, we can this is basically mitral valve ballonoplasty or balloon mitral valve. I am just telling you some treatment modality. Then again I will tell. So you just imagine surgery is not usually recommended in asymptomatic patients. Patients with few symptoms that are otherwise healthy should have surgery. Patients with severe mitral stenosis should have surgery. So indications of surgery are more complex than mitral stenosis. Patients with mitral regurgitation with mitral stenosis become symptomatic only after LV function has been severely and irreversibly damaged. So you see, already I have described about this CMV. One is balloon mitral valvotomy, and another is closed mitral valvotomy. If you see, this is mitral valve. So what happens? They come through the lateral thoracotomy and they enter through the LA to the LV. By finger, they will dilate the mitral valve. This is closed commissurotomy. Left anterolateral thoracotomy, pericardial sac opened longitudinally, suture and tourniquet placed. Surgeon index finger is introduced through opening of clamp removed so that LA and MB can be digitally explored. Transventricular dilator introduced through a small incision. Why closed mitral commissurotomy, not MVR, mitral valve replacement? Because it is very simple, it is rapid, it is very cost effective, low likelihood of ending in valve replacement, and also there is no need to maintain the INR in patients having valve replacement. What are the disadvantages? Restenosis rate varies greatly, not exact science, limited use, and high risk of intra-op embolism. Another one is open commissurotomy. What happened on open commissurotomy? This is median sternotomy, wide arterial excision made valve exposed, annulus, leaflet, commissures, cordis, and papillary muscle examined and analyzed. Mitral valve observed through open atrium as ventricle is filled under pressure. Then decision made regarding reconstruction or valve replacement. These are the mitral valves. What is open commissurotomy then? It is relatively safe, preferred to valve replacement, but disadvantage again cardiopulmonary bypass and sternotomy. Another one is ring annuloplasty. I will tell in once mitral valve regurgitation will come. How mitral regurgitation? So in rheumatic, what I told you, in mitral stenosis, rheumatic heart disease is the most common. First, second, third, if you ask me, it is most common. But in mitral regurgitation, it may not be the first, but definitely again rheumatic cause is most common. Other is like congenital, like degenerative myxomatous valve, endomyocardial fibroelastosis, mitral annular calcification, some papillary muscle dysfunction in ischemic heart disease, and in infective endocarditis. You can see the carcinoid syndrome, some radiation, SLE, tired drug therapy. So in mitral regurgitation, what's happened? If you see, this is the mitral valve. Why mitral regurgitation occurs? If the valve will not coapt, not close, then definitely regurgitation will occur. These causes are many. If there is calcification, there is fibrosis, there is thrombus, there is trauma, and some fixing of the valve. Basically, there is difficulty in coaptation of the valve. So it may be in the papillary muscle level, it may be in cardi level, or in the valvular level. Another one is mitral valve prolapse. How prolapse? If you see, there is two. One is anteromitral leaflet, another one is posteromitral leaflet. If one leaflet is prolapse, not coaped, so definitely what happens? So there will be leak from the valve. And again, it little bit presentation is little bit different. What I told in mitral stenosis, the most commonly patient presented with dyspnea. Here, the most common pain is the fatigability. Patients, because of the mitral regurgitation, the cardiac output will be low. Patient will present with the weakness, fatigability, and once patients having severe mitral regurgitation, dilatation of the left atrium, left ventricle, LV dysfunction, then patients, when there is compliance, compliance will be very poor and not able to manage the LA pressure. Then the LA pressure will be increases. Again, pulmonary venous pressure will be increases. Then PA pressure will be increases. The patients will be symptomatic. But in acute mitral regurgitations, patients left atrial pressure is not able to cope. So immediately patients went into pulmonary. Just imagine in simply patients having acute mitral regurgitation and patients with chronic mitral regurgitation. Chronic mitral regurgitation lead to failure when there is LV dysfunction. There is severe mitral regurgitation. Pressure of the LA is not able to compensate. Then it will. But in acute mitral regurgitation, the patients immediately went into acute pulmonary. So these are the common symptoms like effort intolerance, fatigability, and if you feel the pulse, either like in mitral stenosis, it can be absent, reduced, but usually it is a rapid rise and fall. And here what happens, you can find the apex is forceful, diffuse, and outward. And impulse is constant. What happens here? Fast start sound is soft. Already we saw in already I have described in mitral stenosis. Fast start sound is loud. Here what happened? Fast start sound is soft, and pulmonary component is P2 is loud because of the PA pressure is increased. And sometimes we find S3, which is very rare, extremely or not in mitral stenosis. So again, if you see from diagnosis, we have to basic like ECG, X-ray, and echocardiography. Again, here also echocardiography is the treatment of choice, is the gold standard. You can know the morphology of the valve, morphology of the muscles, papillary, cardi, and you can see the coaptation, the prolapse. Again, you can see the LA dimensions and the left ventricular functions, the LB dimensions, everything you can know, and the pulmonary pressure from the echo. You can see the mitral regurgitation, and you have to see from the mitral regurgitation jet whether it is mild, moderate, or severe. And atrial fibrillation is the commonest complication, pulmonary hypertension, LV dysfunction, and inferior endocarditis. Here you can find inferior endocarditis may be a cause. That means suppose a patient is having mitral valve disease, inferior endocarditis, mitral regurgitation, or in mitral regurgitations lead to inferior endocarditis. So treatment, medical treatment, you have to give antibiotic prophylaxis, ACE inhibitor, and beta blocker. And in surgical, here there are many methods came, surgical and some percutaneous also. But first I will deal with the surgical. Like here what happens, either you can repair the valve or you have to replace the valve. There is only two methods. How you will repair? So when there is basically when there is a pliable leaflets and normal cardi and papillary muscles, then there is a question of mitral valve repair. Another one is ring annuloplasty. The role of ring annuloplasty is to correct, to prevent further annular dilatation, increase leaflet coaptation, reinforce annulus following repair, keep tension of fragile suture lines, and restore the size shape of the valve. You can see the valve annuloplasty. Inflammatory endocarditis, the treatment again is the surgery. When there is acute ischemic mitral regurgitation, rheumatic heart disease, and degenerative heart. So again, the method is the sternotomy, right thoracotomy. Now it is not essential because all mitral valve surgery will be done by the sternotomy. Now minimal invasive surgery, lateral thoracotomy is used very often, and already patient have to keep on cardiopulmonary bypass. And valves, we have to choose whether it is a mechanical, bioprosthetic, and the most important is caudal preservation. Evidence suggests that preservation of the caudi and postolift mitral valve is important in maintaining the normal LV function. Complete excision is necessary in endocarditis with infective tissue, heavily calcified valvular apparatus, and mitral valve replacement is a higher mortality than aortic valve replacement. Two most important factors are LV function and age group. So valve in mitral position degenerate faster than aortic or tricuspid. Sometimes in mitral valve surgery, we have to the tricuspid. Sometimes it need because of the very high pulmonary pressures and tricuspid valve regurgitation, which is lead to secondary to mitral disease, needs the mitral valve tricuspid valve repair also. So this is very important. Even after mitral valve surgery, if will leave tricuspid valve itself, then patients again came with failure, heart failure symptoms. So it is very essential to deal with the tricuspid valve also. So if you will see the valves, basically we have to choose the first we have to select the patient's age group. Patient is a normal sinus rhythm or not, patient's the financial conditions, and then only we can choose and the before giving a mechanical valve or bioprosthetic valve, because we know in mechanical valve we have to keep the INR, what is the Prathamic INR, international normalization ratio, to be maintained in mitral valve. They are about 2.5 to 3.1 in mitral valve. So it is very essential because you have to take a lifelong anticoagulants. In bioprosthetic valve, only you can give either 2 to 3 months of anticoagulants, or simply antiplatelet can manage. So it depends in what is the age of the patients, whether patient is in normal sinus rhythm or in atrial fibrillation. Because in atrial fibrillation we have to give in anticoagulant, but still nowadays patients are preferring to bioprosthetic valve. Only problem in bioprosthetic valve is it degenerate faster, but still the third generation bioprosthetic valve, we can implant, and the longevity they are about 2 decades, they are about 15 to 20 years. And here what happens, patients have a relaxation of anticoagulation, the most important part, because we know what is the complication of anticoagulants, from the not maintaining INR, from the stop valve to the cerebral vascular accident. So the most important, bleeding tendency. Then in the redo surgery, if in stop valves or patients having very early progress to the again recurrent mitral stenosis, then our valve area is diminished, then we can go for redo surgery. But again, once they reduce surgery in mitral valve, again it is very costly, very morbidity and mortality very high. So but one thing is, in bioprosthetic valve, we have another chance of valve-in-valve surgery. So TMVR, transcutaneous mitral valve replacement, that is nowadays in either it is very good in patients having mitral valve with bioprosthetic or annular ring, so it is good. Another thing is mitral valve clipping nowadays. In severe mitral regurgitation, in non-ischemic or having patients with many surgeries, those who are not ideal for any surgery, this is not an ideal candidate for surgery. You can go for mitral clipping. There is no need of surgery. You can just clip the two leaflets, and you can reduce the mitral regurgitation amount, and patient will be symptomatically improved. But it is very costly. Still, nowadays it is some indications in severe mitral regurgitation. So in total, our drawbacks in mitral valve is, one is difficulty in diagnosis, because sometimes patients presented many times dyspnea with bronchial asthma, COPD, or any dilated cardiomyopathy. So echocardiogram is one of the most important diagnostic parameter, and the investigation of choice to diagnose and to classify, to stratify the diseases, mild, moderate, severe, and also what the need of surgery on mitral valve valvularity. Again, in mitral regurgitation, whether you can go for annuloplasty, you can go mitral repair, you can go for mitral clipping or surgery. That also decided by the echocardiography. And for treatment modalities, medically it is only diuretics, beta blocker and ACE inhibitor, and the mitral fibrillation, then digoxin, and third is anticoagulation. Patients without surgery, only atrial fibrillation with anticoagulants, and patients with atrial fibrillation and surgery and anticoagulation. Fourth is cost effective. What is the cost effective for the patients? Which surgery or which procedure is fit for the patients? And patients, because usually this, we know this mitral valve diseases is very common in low socioeconomic status. So I think we have gone into details in the mitral valve surgery. If